Welcome to the Clinical Consultation Network, everybody. Glad to have you today. I have been off for a week. I was not here last week, and Michelle Bagby filled in very well, I understand, in my stead, so I'm very appreciative to Michelle for that last week, and hopefully she is prepared now to be able to fill in at other times when I may need her to do that. We certainly hope, and as well as other members of our team at some point. So thank you so much, Michelle. And so we've got a really great case today to discuss from someone that we've heard from before, Nurse Ann Worley. She's one of our mortality nurses in the East Tennessee region. And my co-host today is going to be Bill Feldhouse. Bill, say hello to everybody.
I had to unmute, but hello, everybody.
Yeah. So glad Bill is here with me today. And so Ann has a very interesting case for us to discuss, and I'm going to let her take off with that here in just a minute. We've had lots of interesting cases here recently, and I was just thinking, what I'd like to do is just advertise to everybody, let everybody know that we want your cases. If you have some interesting cases out there, we'd love to have them in here to discuss them. In fact, we were talking a lot today to a group of TENCO members about sexuality, and so if you have cases that have kind of interesting, rabbit trails with respect to sexuality, we'd be very interested in hearing about those. Sexuality is one of those issues where there are no solid, black and white answers to a lot of the questions that come up about that. And it really is important for people in our systems to practice their thinking about those types of situations, practice their analysis of those so that you can give proper advice, because there's not just one question to ask yourself as you approach a situation like that, and particularly with some of the complex situations that we have out there. So if you have a case like that you'd like to present at some point, I would love to hear that. It's just I think it would be a great discussion for us to have here on the Clinical Consultation Network. And of course, there are other matters of consent, rights, and other things of that nature that I think will be very interesting. And in fact, the case we discussed a couple of weeks ago was one where a circle of support was considering conservatorship for a person who was making some unwise decisions at best, and so as a result of those unwise decisions, the circle of support was considering possible conservatorship for this person. And so, as we discussed that a couple of weeks ago, we didn't quite get all the way through that topic, but we did kind of explore a little bit this whole notion of capacity to consent and what our real goals are with a person like that who may be making some unwise decisions. So we're going to actually have an opportunity to follow up on that case in a couple of weeks. Trey King, are you on the phone? Can you remind me when it is that we're going to follow up on that case?
Yes, it's in 2 weeks. Let me get the exact date early on. That will be October the 8th, I believe.
October the 8th. So if you didn't get an opportunity to get in and ask your questions or give your input on that case, we are going to be discussing that again in a couple of weeks. So that I encourage you to be available for that conversation. And we've got another one. Let's see, what do we have scheduled for next week, just to give people a little bit of a heads up about that. Does anybody I'm trying to remember what we had on tap for next week.
I'm working on pulling it up. Next week, Andrew Hinkle will be presenting and discussing alternative conditioning referral and several trials to find appropriate equipment.
Excellent. he's going to tell us about his assessment process and getting the right equipment for a person in receiving the positioning clinic. So that's going to be a great case as well. So looking forward to these next couple of weeks here on the Clinical Consultation Network. And I'm so happy, again, to welcome Ann Worley here with us today. And Ann, so you presented a case. You're a mortality nurse, so that means, unfortunately, that you work with people who have died, and you work with their cases, I guess I should say. You try to understand the reasons behind the death and what we can learn from those. And so you brought a case to us today to discuss. But before we launch into that, I'd like to have you just tell us, remind us a little bit about yourself and how you got into this work in BADD.
Okay, thank you for having me. I've been a nurse for 33 years, and I started out in ICU and ER and before I came to Green Valley, and it was kind of a culture shock going from that kind of environment to working with people with intellectual disabilities. But I had a love, even in the ICU and ER department, taking care of people that needed a little bit of extra care, a little bit of time to explain things in their way of thinking and knowledge. So that's kind of how I did. And then I got to be one of the lucky people that got to stay on with Central Office when Green Valley closed.
Okay, yeah, and so you're an East Tennessean.
Yes.
Are you a Vols fan?
Yes, I have to be. My husband would kill me if I didn't.
It's been tough this year. I am too, but it's been tough this year. We're glad to have you today, and thank you for bringing this case to us. I wonder if you might just kind of launch in and tell us a little bit about this person and give us a little background on it.
Okay. This lady was 53 years old, and she was a very interesting lady. She was very pretty. We're going to call her Sandy. And she liked to look, dress nice. She liked to have her hair done. She liked to go to the beauty salon, get her nails done. But she also liked to lay on the couch, watch TV, take naps. She liked to have parties and attend parties, but she didn't want anything to do with the preparatory part or the clean-up part of having the parties. She had a doll collection that she was very proud of that she displayed in her bedroom. She had a history of coming up with illnesses, and sometimes they were spot on, and sometimes they were not, because it was attention-seeking behavior. She liked to go to the hospital. She liked to go to the doctor, where most of us try to avoid that. She liked that attention. So staff had to be real conscious when she...
Was it always physical illnesses, or was she saying that she had a physical illness? Is that why she was going to hospital? Okay, so it wasn't like she was having a behavioral outburst or anything. She was just saying make physical complaints. Am I understanding it correctly?
Yes, but she did have behavioral outbursts too.
Okay.
Yeah, she had those, but she had one episode where that she went to the doctor's office for a routine visit, and she ended up in the waiting room exposing herself to everybody out there by pulling her pants down. So the staff had to redirect her, and she got upset when they redirected her. So she had a lot of attention-seeking behaviors, I think.
That was right out in the waiting room at the ER. Did that happen? Okay.
Yes. She had a sister that also had developmental disabilities, and her father took care of the sister, but I think that it was harder for him to take care of Sandy. So Sandy ended up going to Orange Grove until she was 19 years old, and she was very familiar with psychiatric institutions. She had been at Lakeshore, Ridgeview, Moccasin Bend, Matt T. Winston, and she had had several behavioral respite facilities that she had visited for like 2 weeks span at a time. so that they could change her medicine and try to come up with a plan that was more appropriate for her. Okay? What I was going to do is I was going to go through some of her diagnoses, explain what the diagnosis is, and kind of how it affected her.
Sounds good.
Okay? The first one was intermittent explosive disorder. That's a sudden episode of unwarranted anger. A lot of times she thought that her roommate wanted to fight or staff wanted to fight her. So out of the blue, she would jump up from the couch and she would start trying to fight either the staff or her roommate. She had passive aggressive personality. That's indirect resistance to the demands of others and avoidance of direct confrontation. Now, I have a little bit of question about the avoidance of direct confrontation because she was one of these ladies that was in your face.
Yeah. Well, and that sounds like a little bit of a non sequitur with her jumping up and challenging people to something, although I can see where maybe being a little bit passive aggressive might lead someone to that. Like, you know, a passive aggressive person might kind of be passive for a long time and then, you know, suddenly have an outburst of that type, you know, in response to sort of, you know, repeated acceptance of different circumstances. But usually when we say passive aggressive, that means you don't act on things. You kind of act aggressively by not doing much and by not responding to what other people want. So there does seem to be a little bit of a non sequitur there.
Right. She had schizophrenia, which is a breakdown of thought, emotion, behavior, leading to faulty perception, inappropriate actions, and feelings. And I think this one kind of trumps out of all the psychiatric diagnoses that she had.
Yeah, you know, that I was had already started asking myself the question about whether she had a psychotic diagnosis like schizophrenia, because what the description that you gave of intermittent explosive disorder made me think that she might have had some paranoid thinking that would have prompted her to respond that way. So where it appears intermittent maybe to others, it's not so intermittent to her because of what's going on internally.
Right.
Do you think does that sound accurate or valid in that case?
You're right on.
Okay.
She had delusions, altered reality despite evidence contrary. I never seen any documentation. She also had psychosis, severe disorder, loss of reality. I never had any staff that had documented anything about hearing things, seeing things, or kind of an altered reality, because it sounds to me like this woman was very intelligent.
Oh, okay. So you didn't actually see that she had hallucinations of any kind, where she was seeing things that weren't there or hearing things that weren't there.
The staff never documented it.
Okay. That's kind of an interesting thing. You know, the paranoia could be considered somewhat of an alternate reality to some degree, because that is, you know, sort of having this idea that somebody else is trying to do something to me when they're really not. Of course, you know, sometimes we do discover that people really do have there's something happening, but in this case it sounds a lot like she was having paranoid thinking, which would be, as far as a symptom of schizophrenia or a psychotic disorder, would be more of a delusion, perhaps, than a hallucination. Hallucinations would be things like you're seeing things, maybe hearing voices that are repeated, and those types of things. So as far as one element of a schizophrenic diagnosis you saw, which was the delusional aspect, you didn't necessarily have a lot of evidence that she was having hallucinations, which would be another of the criteria for that.
Right.
Okay.
She also had anxiety, and that's excessive, persistent worry and fear of the everyday situation. And she did exhibit this because she had a constant fear that somebody was going to steal her personal belongings. She would even take food items and she would put them underneath her sheets and stuff in her bed to prevent somebody from possibly stealing her stuff.
Did she have any real reason to think that that was going to happen? Because she was in an institutional setting there, and so, you know, I have seen people in institutional settings who would be concerned. I mean, rightfully concerned that others might intrude and take their property.
Well, she was living in a community home where there was only another lady that lived in the house with her at the time.
Okay, so you had, but I was thinking maybe you had observation of her when she was at Green Valley, but your some of these observations came from when she was in the community setting,
right,
and just had one other peer there.
Right.
Okay.
And then she had the diagnosis of depression, persistent feeling of sadness and loss of interest. Well, she considered herself to be retired. She didn't want to go to work. She liked laying on the couch watching TV. She wasn't really active in the community. She didn't want to, she'd had jobs before. She just didn't want one. And to me, I thought maybe that's part of the depression instead of her just wanting to lay on the couch and watch TV.
Mm-hmm.
Maybe that has something to do with it.
Can you remind me how old she is?
She's 53.
53.
She was 53.
Oh, well, 53, yeah. All right. Well, yeah, she's got a laundry list of diagnoses here. And maybe what we want to try to do toward the end is see if we can sort it out a little bit and figure out what some of the primary issues are, but I don't want to jump the gun with that, so why don't we go ahead and hear the rest of the story and then we'll come back to that. But I do see your point, you know, I mean, and sometimes it might be difficult to kind of distinguish between, is this person really depressed? You know, is there some sort of physiological endogenous depression that they're experiencing, or is this just a kind of a lifestyle that she's developed? So let's hear more, and then we can return to that.
Okay. Another thing they had put as a diagnosis was abnormal EKG. And that can mean several different things because too much sodium, too much potassium intake can cause an abnormal EKG reading. And I didn't see the actual EKG, so I don't know what the rhythm actually showed on there. So that was kind of unusual because, I mean, that could be anything from, you know, an altered rhythm all the way up to somebody getting ready to have a heart attack.
Yeah. So that's interesting, and had that been on repeated measurements, or was that just like one EKG? I mean, so she was diagnosed, you're saying, with abnormal EKG, and I'm just trying to figure out, was it a chronic issue or was it isolated to? Why did she get the EKG? I guess that's the question I want to ask.
See, I don't know. Sometimes when the nurse practitioner writes a list of diagnoses, there's all kinds of stuff that's on there, and we're trying to figure out how did that happen? Is this something that's been lifelong, or is this something that just occurred? And if the PCP or the physician doesn't document, you know, it kind of leaves it wide open to speculation that we don't know what happened.
Well,
and that's just one of the diagnoses.
Yeah, it's such a critical thing, and I think it warrants taking a moment to underscore that we need to get that type of information because it really might help us understand this whole case differently. People who are under cardiac stress behave differently than other people, and so there is a possibility that this medical condition could have been at least a contributing factor to some of the other issues that she was dealing with. So it's always, I think we want to press for that type of documentation and to have those types of understanding as we're working with people day to day and as we're taking them to doctor's appointments so that we can clearly kind of be able to refer to that history to understand what's going on with them.
Right. She also had anemia, which is low red blood cells. When you looked at her labs, they were low, 3.63 to 4.03, normal being 4.3 to 5.9. And she was taking iron supplement to try to help that.
Okay.
But that can affect it too.
Yeah.
She had constipation and
So let me return to something there. And I'm just brainstorming a little bit right now, but and maybe this is something you're going to cover a little bit later. If so, I'll kind of move on. But so you said she was anemic, right? And so one of the effects of being anemic is that you're low energy, correct?
Correct.
And one of her psychiatric diagnoses was depression. So, I'm just putting some two and two together. I'm not saying one caused another or anything else. I'm just pointing that out. So that's just another thing I think we want to keep in mind as we move forward.
Okay. She also, and this is the first time in my years of nursing, and Bill and David may have seen this before, but I've never seen anybody diagnosed with adult hypothyroidism and hyperthyroidism at the same time.
That does seem strange.
Okay. So this is my nursing.
Yeah, that's got to be two different people making the diagnosis at two different times, and it just got left on the chart. I mean, that's impossible, isn't it?
Well,
to simultaneously have that.
Right. But she probably had one at one time, and maybe it was over-treated, and another time, so that made it low or whatever, and they both diagnoses just got left on. Just gets back to that getting accurate information.
Right.
I was wondering, you have hyperthyroidism, which is, the thyroid gland can get enlarged, can lead to Graves' disease. But, if it's enlarged, does that automatically mean that it produces the same amount that it needs for the body? Could it not be enlarged in hyperthyroidism and still not producing enough thyroxine, which is the hormone that causes the hypothyroidism?
Well, isn't the measurement, though, the amount of thyroxine production?
Yes, but she was taking Synthroid, which is supposed to help that production. And when you looked at her TSH level, it went from 1.060 to 4.290, high being anything over 3.74. And, there was at least one time that she had an overproduction of thyroxine.
Well, so one wonders if maybe, I'm not going to really even speculate how you ended up with hypothyroidism under that circumstance, because ultimately, and unless someone diagnosed that not knowing she was on Synthroid at a particular time. But if anybody else has another a brighter explanation of that, please jump in.
Keep it in the back of your mind, because when we get to the autopsy, this is going to be very an intricate part that will kind of tie this together.
Well, and let me also just mention hypothyroidism, to the extent that that's valid, is a potential contributing factor to depression as well. Just throwing it out.
That's why I said this case is very interesting.
Yeah,
because I kept saying, what? Okay, another thing that she had was constipation, which a lot of people do, a lot of the medication that they're on.
Bruce? Dr. Bruce?
Yes.
This
I'm trying to jump in. Please,
yeah, I'm sorry for jumping in. You can go from hypo to hyper if it's not treated well.
Okay.
So I just kind of want to put that out there. So I don't know, and I don't know what her levels were before when she was. You can go from in a thyroid storm, you can go from hypo to hyper.
Well, and I guess if you're being medicated for hypothyroidism, so in other words, you're getting more thyroxine, then you could be kicked into a hyperthyroid state.
That's correct.
I'm not saying this the right way, but I'm just trying to muddle through here with the experts.
Yeah, that's why I wanted to kind of put that out there.
Yeah, all right. That's a good point.
Thank you for saying that. That is. She had constipation, and she was on several things, lactulose, stool softener, and she was on Linzess. That is the new irritable bowel constipation super drug. And I looked it up because I didn't know much about Linzess, and it said that it increases the fluid in the intestines, and it speeds up the movement of the food in the gut. And this will also be very interesting when we come to the autopsy part.
So that was something she was taking because she was. What would be the reason that you're taking that you would need to speed up the digestion process?
The nurse practitioner had ordered it for constipation.
Okay. All right.
She had coughing down as a diagnosis too. Well, she had a diagnosis of dysphagia and GERD. Well, if you have reflux, that can cause, if you get enough of that gastric acid and stuff in your esophagus, in your mouth, that can cause coughing. So I don't know. It may have been a side effect of a medication. And she had also had Barrett's esophagus, where that she had ablation done, and ablation is where they take and they try to burn off those cells on the esophagus to prevent cancer. So she had that done in the past too.
And you mentioned and she had I'm trying to make sure I'm tracking through. You mentioned she had a diagnosis. Did you mention that she had a diagnosis of GERD?
Yes.
Okay. Wanted to make sure that I understood that correctly. So that would be the primary cause of Barrett's esophagus. Am I correct in that?
Yes.
Okay.
And she was on
Yes, please jump in.
Yeah, sir, no, it's Michelle. I just wanted to point out, Kim Gibson had a comment in the chat box that says, I would say she had complications with her thyroid and she was probably diagnosed during acute episodes of which can be high at times and low at times.
Okay. Thank you for that, Kim. All right, Ann, we'll let you proceed now.
Okay. She was on Nexium and Zantac, and usually you don't see them on two different ones unless it's poorly controlled. So with her dysphagia, the difficulty swallowing, and the GERD, and the past history, that may have been why that she was on two of them. She also had high cholesterol, and her cholesterol levels were good. They were less than 200, and she was on Zocor. And Zocor was for the cholesterol and for the triglycerides. She had the diagnosis of high-risk medication use. And I thought about that and thought about it, and I thought, why did she put that on there? And it was probably because she was on so many medications, and they have so many potential side effects and so many potential adverse reactions that she wanted them to know that, with being on a lot of medicines like this, that, bad things can occur.
Yeah.
She also had obesity. She was overweight. She weighed 185 pounds, and she was 4'11".
Okay.
She had edema in the foot and ankle, and she had a speech impairment. Now, the medication that she was on for the psychiatric diagnosis was anti-epileptic. She had two anti-epileptic drugs, valproic acid and gabapentin, that are a lot of times prescribed for mood, and that's what she was getting them for.
Mm-hmm.
She was taking Ativan, which is an anti-anxiety drug, and she was on Seroquel
I was just about to predict she was on Seroquel.
for mood and psychosis.
Yeah.
And then she was on cocaine.
Let me ask you a question about her edema and the condition of her legs. Did she have difficulty ambulating?
Well, they said that she had a disturbance in her gait instability and balance problems. So I don't know if that was related to that or if it was related to her blood pressure. You know, her blood pressure run between, and I'm going to go over that here in a minute too.
Okay. There's just a ton of stuff to go over here.
Yeah.
I'll let you proceed.
When I was looking at a lot of this stuff, I was looking for a questionnaire because I wanted to actually put her in this and see how that she did with heart disease and heart attack. So WebMD had what they call a 6 main risk factor, which was really a 7-point questionnaire. And it asked, do you smoke? Well, we didn't have any history or evidence that she had ever smoked. Number 2, high LDL, which is your bad cholesterol, or low HDL, which is your good cholesterol. Well, I already told you that she was on Zocor for her cholesterol, and that it was good. It was less than 200, but her triglycerides were high. They were between 170 and 232, and normal is less than 150. Her LDL cholesterol was normal. It was 64 to 82, and normal was less than 130.
Just a quick question on triglycerides. What is the main treatment for that? Is there medication that's taken for that, or is there some other treatment that you undergo for high triglyceride level?
The Zocor is supposed to help with that also.
Okay. So the same medications that treat high cholesterol would treat high triglycerides as well.
Well, there may be some. Bill, do you know, are there some that's specific for triglycerides?
I couldn't say for sure one way or the other. But usually it's the diet.
It's a combo.
Thing to get those down, yeah. Or it was that when I was working out in the field.
Right.
Okay.
The third question was, do you have uncontrolled hypertension? Well, if you looked at her baseline, it was usually around 120/90. Well, the 90 is not good because that's when your heart's supposed to be at rest. But she was not on any antihypertensive medication. Number 4, are you physically inactive? Well, she considered herself retired, and yes, she liked to sit on the couch and, you know, watch TV. So I don't think she was getting a lot of physical exercise. Number 5, are you obese? She was 4'11", weighed 185. Her BMI was 37.37. So, yes, she was obese. And number 6, do you have uncontrolled diabetes? Well, all of her blood sugar levels were normal. They were like 90 and below. But her A1C level shows 5.5, and it's getting up there to the point where you're almost pre-diabetic.
Okay, explain that terminology there, A1C. Tell us about. I've heard that before, but tell us a little bit more about it.
What that is it's a blood work that shows the past 3 months of your blood sugar levels. So if you've been cheating and you go to the doctor and they do what's called an AccuCheck, stick for your blood sugar, then it's going to show what's happened in the last probably 24 hours. But if you get an A1C, it's going to show you the true level of what your blood sugar's been over those past 3 months. So if you've been drinking milkshakes and eating candy bars, then it's going to show on that.
Okay, so it's a lab test that it's able to kind of discern more of a longer baseline period, essentially, where I'm able to look at a 3-month period, as you were just saying, versus just what it is right at this moment.
prescribed.
Okay, that's helpful. So the 5.5 that she had on that indicated that she had a lot of her blood sugar had been consistently high. Essentially, am I saying that right?
Yes, and then I looked at her diet. Her diet was low fat, low sodium, high fiber, low cholesterol, with GERD precautions. So, I mean, you'd think that would be pretty good,
Yep.
but a lot of times when you're doing low fat diet, you're doing high carbohydrate diet. And when you're doing high carbohydrate diet, then, you know, you're still increasing your blood sugar level. So what she was actually eating, you know, I'm not sure, because a lot of times what you see documented is not the reality of what's actually going on.
I can tell you this, and my doctor has told me consistently to watch different things about my diet and has prescribed diets, and I usually try to follow them good, but a lot of times I don't. So the reality is everybody doesn't always follow exactly what's in place. But I don't know if that's the case here, or if maybe it's just what you were saying, that there was somehow, if we were decreasing these other things, we were increasing something that may be problematic.
I think that's true. And then the last question it asked was, do you have uncontrolled stress and anger? Well, I think she probably got a 10 out of 10 on that, because there was lots of documentation of hitting, yelling, cursing, spitting, threatening to do bodily harm to other people.
Yeah, and living that kind of lifestyle is stressful. You know, when you're constantly upset like that, and you know, it's putting a lot of pressure on your body to respond, and so you know, obviously that's something that might stress your heart.
I agree. Now I'm going to go to the terminal event. The day that she passed away, she was in a respite facility because of her threatening her roommate, and she'd been there for about a week, and they had not changed any of her medicine. They were just kind of observing her to find out, you know, what does she need, what do we need to do different. And she got up that morning, and she said she wasn't feeling good. Well, you know, you have to go back to, in the beginning, a lot of times she would say, pretend to have illness so that she could get attention. So, you have to really pat the supervisor on the back, because she went ahead and done the right thing, and she called the doctor, and she said, you know, we've got Sandy here, and she just don't feel good. You know, she's not really complaining of anything, but, you know, she just acting like she don't feel good. So the doctor said that he would come by and he would check her. So
let me just make the point. I think you were highlight the point I think you were just making, because it's so important. What you're saying is it might have been easy to kind of dismiss what she was saying, because she so often had physical complaints, and you know, it might have been even difficult to tell if she was having physical complaints because of the way that she was, you know, her lifestyle of being on the couch all the time, and you know, probably often looking like she didn't feel that good anyway. So is that kind of what you're getting at? And you're praising this home manager for saying, okay, I'm not just gonna dial it in. I'm not just gonna think, okay, she's feigning an illness here, but she actually went the next step to get her checked out.
Yes, I think that she needs to be commended for that. But the doctor said that he would come by and he checked her, and when he said, Sandy, what seems to be wrong, it changed. Every time that he would ask for something, she'd be like, oh no, it's my arm, it's my stomach, it's my throat. And so the complaints kept changing as the doctor was checking her. Her abdomen was slightly distended, but when you look back on her last physical, it was distended then. So, you know, with the constipation, and remember I told you that we talked about the lenses and the fluid and stuff a little bit later with that. It made you wonder the fluid in the stomach, I mean, I don't know that much about Lindsay. I was having to do research to try to find out, you know, can it cause your abdomen to swell? If it's increasing the fluid to that area, it would almost think that it could.
Okay.
But when the doctor listened to her lungs, they seemed to be okay. They were a little bit decreased, but they were audible. He listened to her abdominal sounds, and they were present, but they were low or decreased. And
so let me ask this, because I'm just going to hit this quickly. But he's listening for abdominal sounds because she's distended, and if she had some kind of a bowel obstruction, you wouldn't hear those abdominal sounds.
Well, you could possibly, but, you know, would they be decreased? But there's a lot of variable things that can cause your bowel sounds to be decreased.
Okay.
So unless you have an
X-ray
done,
yeah, gotcha.
Unless you have an X-ray done, there's really no way to actually know for sure.
Okay.
But he told the staff to go ahead and to encourage fluids, but not food. And he would check her again that night or first thing in the morning. So he left, and around 3 o'clock, she ended up having a toileting accident on herself. And so staff took her to the shower. They helped her get changed, and she come back out, sat on the couch, watched more TV. And right before 4 o'clock...
was the toileting accident typical for her, or not? Was that atypical, or...
Yeah, I think that was atypical for her.
Okay.
But they got her cleaned up. She went back and sat on the couch. And right before 4 o'clock, she got up and she was going to change seats. She wanted to go from the couch over to the chair. Well, she never made it to the chair. She went straight to the ground and started having some involuntary jerking movements. Now, she had the diagnosis of tremors of the nervous system already, where she done some shaking and stuff. She never had a seizure disorder, but the staff felt like that she was having a seizure, so they called 911. So give them another pat on the back because they immediately knew that she needed assistance past their quality of care that they could give. And as soon as they got beside her on the floor, they turned her over to the side, and she vomited a black substance. Well, you know, when we see that black substance, first thing we're thinking of is old blood. You know, so in my mind, I'm thinking, okay, she's had some kind of tear, a rupture, aneurysm of, you know, the abdominal aorta, something that's going on with that. But the fire department got there, and within 5 minutes, they hooked her up to the AED, and it said no shock advised, and she was flatlined. She had already passed away. Her body core was cold to the touch immediately, within 5 minutes, her whole body. And I thought that was very unusual too.
What was unusual about that? Tell us more about that.
Usually, when you have rigor mortis happening, it's usually not just one area. It usually starts where it starts pooling of the blood, and the body starts slowly but generally along the whole surface of the body getting cold. It's usually not all at one time.
You would have expected that process to have occurred more slowly.
Yes. Yes, I thought it would have, but with her it did not. It was immediately. Within 5 minutes of within 5 minutes of falling to the floor and somebody thinking you're having a seizure to being totally cold to touch. I thought that was very unusual. But they sent her body for an autopsy, and the medical examiner had 10 different diagnoses. The first one was morbidly obese, which we knew. She had external hemorrhoids. She had ascites. Ascites is when you have excess abdominal fluid. Now, you can have this from heart failure, cancer, cirrhosis of the liver. But, you know, it made me think, you know, that Linzette increases the fluid in the intestines. I mean, is it a coincidence?
Mm-hmm.
Maybe. I don't know. She had cerebral cortex atrophy, which is the brain had shrunk a little bit. And that's probably something that she had since birth.
You said that it had shrunk. Okay, you said, okay, I'm sorry, you just clarified it while I was thinking of my question, because you said she had that from birth. So it wasn't really a change from a previous evaluation. It was really just basically noting that she had the condition of cerebral atrophy.
Well, you'd think that, you know, something like that would not be acute. You'd think that's a chronic thing that, you know,
right.
However the size of your brain is, it's probably not going to shrink as you get older. We'd all be in trouble.
Well, yeah, sometimes I think mine's shrinking, but, you know, yes, I understand what you're saying. And so somewhere through the developmental process, and then, you know, that there was cerebral atrophy, but that was more or less a standing condition or a chronic condition that she had.
He didn't say that, but that's what
more than
I assumed, and sometimes you know what happens when you assume things, but
right. Yeah.
I don't know. She had single microscopic focus myocardial fibrosis of the ventricular septum, and all that means is she had scar tissue in the lower portion of the heart. And a lot of times that's indicative of a heart attack, but, you know, he didn't say that.
Mm-hmm. So that could have acutely occurred, that scarring?
Well, if she had a heart attack, it would. But he didn't say that. That's why I said this one's kind of like a mystery, because you're like, okay, tell me more, and he don't tell you more. She had chronic bronchitis, which is inflammation of the lining of the bronchial tubes that go down into the lungs. Maybe that's why that she was doing a lot of coughing. You know, I mean, I'm trying to put two and two together here, and sometimes I'm coming up with six. Status post ablation of Barrett's esophagus, which we already knew. Arteriolonephrosclerosis, which was mild, and a lot of times that's a progressive renal impairment caused by the chronic, poorly controlled hypertension. Well, you know, we don't know what her blood pressure was all the time because they weren't taking it on a routine basis. So if she only went to the hospital or the doctor, and that's when that she was getting her blood pressure took at that time, and if she was throwing a fit or she was trying to fight somebody, of course her blood pressure is going to be higher. So that was one that, you know, they may not have been able to put two and two together there either.
So what was that? So is Barrett's esophagus, and then what was the condition that you knew? I know you were talking about blood pressure there, but what was the condition that
it's arterial nephrosclerosis.
Okay. Which you are saying would cause high blood pressure. Yeah?
It's called, from the blood pressure. If you have poorly controlled hypertension, it can cause that.
See. So when they talk about blood pressure being the silent killer, this is one of the conditions that it causes.
Yes, it can.
Okay.
She had had some surgery in the past. She had had her appendix took out, her uterus, and she had post-bilateral tubal ligation that they had documented. And then the last thing was Graves' disease with her thyroid. And hyperthyroidism was what he contributed number 10 to. I just thought that was very interesting when she was being treated for hypothyroidism.
Okay. So at death, he diagnosed a condition that would have been caused by hyperthyroidism.
Correct.
That's Graves' disease. Yeah. Oh, wow.
And then he said the manner of death was undetermined. He did not know what actually caused her to pass away.
Well, I'm interested to hear from the medical folks that we have on the phone if there are any thoughts, hypotheses, and you're hypothesizing that this may have had something to do with heart disease and that she had a heart attack, essentially. Is that your hypothesis, or clarify?
That's my possibility.
Okay. Anybody else out there in medical land have any thoughts about this case?
Well, one thing always to remember is there is almost a twofold risk of sudden death with antipsychotics such as Seroquel.
Yeah, that's an interesting thought. Dr. Schuler, thank you for joining us. Question I had, going back to Seroquel, and my recollection is that Seroquel is not one of those offenders, but she had that abnormal heart rhythm, and I do know that some antipsychotic medications affect the heart rhythms. You know, there's that what they call the QT interval can sometimes be lengthened. That was at least by some antipsychotic medications. I don't know. Is there anything there to think about?
They all cause prolongation of the QT interval. Geodon being the worst, but when the information about Geodon came out, they made it a class warning for all of the second generation antipsychotics. The first generation have it also, though.
Yeah.
They're just not sure if the sudden risk of death is completely related to the QTC or something else. It's just always something to consider,
right?
Because we don't know if she really had a history of psychosis and whether she really needed to be on such a powerful medication such as Seroquel. And so when people die of sudden death and they're on this medication, it just makes you kind of think a little bit more about trying to be hesitant to start them. It might have been, we don't know her, it might have been completely indicated, but I can tell you there are a lot of people that I do see in death reviews that we can't explain their deaths, and they're on antipsychotics, and it just always raises the question.
Yeah, and I think what you're underscoring is the need to take care whenever you're prescribing antipsychotics, because as we were discussing just yesterday, that there are differential diagnoses that you may want to consider in those circumstances, like to what extent is the person's reaction somehow tie into the trauma that they've experienced, to what extent is what they're experiencing related to developmental concerns. That doesn't exactly sound like the case here, although I do recall that you were telling me that she had a tendency to play with dolls in her room. So, there's and having the diagnosis of intellectual disability at the base of it makes you always want to be thinking about developmental concerns that may be involved. So, yeah, trying to rule in or rule out a diagnosis of a psychotic disorder is a critical piece, and it's going to affect a lot of decisions that come after that once that's been done. It's easy to see also where depression became a thought, but when you think about the multiple conditions that she had, it's easy to see where that might come into play. That people would be thinking she would look very depressed. Her obesity, at some point hypothyroidism, potential, sort of heart condition that she was experiencing. Any of these things might have caused her to just not want to engage that much. And I think about that a lot. If I'm serving a person with Down syndrome, you know, a lot of people say, well, people with Down syndrome are stubborn. Well, it's not all stubbornness, because there are a lot of physical conditions, lots of different factors that kind of play a role in them not wanting to move as much, orthopedic concerns, other things of that nature. So, you know, anytime we're looking at a psychiatric diagnosis, looking at those different sorts of physical conditions that may contribute to that are really, really important. This has been a fascinating case, and once again, we have run out of time before we can completely resolve anything, but it has certainly stimulated lots of good questions and lots of good education that occurred in the course of this meeting. I know there were several things that you were able to pass along that were very interesting. I think will help clinicians sort of look at the situations that they're dealing with and look for these patterns that we've been discussing. And so I appreciate you so much for coming on and being with us today.
Well, thank you.
And this has been the Clinical Consultation Network. Thank you for being here, everybody. We do this every week at 1:30 p.m. Central Time. And who knows, you might even get another little cameo by Dr. Victor Schuler, who is here with us today. Appreciate you, Dr. Schuler. And we will see you again next week. Thank you for being here.